November 16th, 2023. It is 5:34. Item number 1 is public comments, and I'm just going to begin by reading a statement. The Board of Health provides the opportunity for the public to share their viewpoints and opinion on public health matters. It is not the practice of the Board of Health or agency staff, many of whom are top experts in their field, to review, vet for accuracy or grounding in scientific evidence, or provide responses to public comments at Board of Health meetings. Opinions expressed by the public should not be necessarily interpreted as accurate if staff of the board does not challenge this perspective. Hi.
Great. We had 2 members of the public sign up to speak. The first is Brian. So Brian, I see you're logged in twice. Could you raise your hand at which one I need to make a presenter? All right, your 3 minutes will start whenever you're ready.
Let's see, is that working? Can you hear me? Does that work?
You're good. You're good.
Okay, thanks. Yeah, I appreciate it. I know you're finally back in person, so thank you for making that shift. I know there's quite a few folks that will be there, myself included, to meet you. It's took long enough. Certainly your management, I think, obviously the slapping your little disclaimer on the front end of this conversation is funny in itself, but you really have dodged and ducked the public at large who you should be serving. So I'll say your management throughout COVID and after brought a number of substantial changes, obviously, to our community in light of the virus. And I'll say it was an enormous net negative for everyone, from school closures that you enacted to the small businesses that were closed and can't come back now. You pushed a lot of unproven and very, very unnecessary measures you thrust upon the community. And I always continue to speak to that because you grossly overstepped the boundary on that in trying to force this whatever intervention it was, fill in the blank, whether we were fronted with vaccine passports, which were probably the most daft idea of them all, to masks and all the above. I think the community is worse off due to all these interventions that you thrust upon everyone. The behavior of local, state, and global governments, I think, was overwhelmingly geared towards panic. We need to fret. We need to be alarmed. It was a little disgusting to hear the conversation of the folks that are dealing with kids. Your last conversation, whatever that session was. Again, parents, if anyone ever listens to this, your kids are not at risk at any adverse outcome due to COVID. Therefore, any intervention, no matter what any of you folks are saying, is completely unnecessary. And if so, then prove it with numbers, as you did day in, day out during the pandemic. Quit skirting that. Another thing, too, you're not being very transparent with is not one of you has come to acknowledge that there's been a single issue ever arising from any vaccine. No adverse effect whatsoever. And I think that's being deeply disingenuous with the community at large. So until you change your position, I'm glad there's a few other folks in the community that are standing up. I think your voices are terribly one-sided, and I think that's incredibly unfortunate. I've always led with health first. I didn't need a vaccine to accomplish that, and I've done just fine through COVID, as have many other folks. So your all-in push is nonsensical. You're clearly working on behalf of these pharma companies. And I think things are crumbling for you. No one's taking whatever number booster you're on right now, and you're kind of seeing it go down the chain. Those companies are failing. Your messaging's not getting out. Now everyone's scared of FOMO. That's your next attack line.
We had one other person sign up for public comment, but I do not see them online, so that concludes public comment.
Okay, thank you for public comment. And I don't know, Jordan, I realized that we have not been doing roll call. Do you want us to?
Oh, yeah, we can start that.
Okay, great. We have a new board member also.
Yes. So we're going to start with an official board roll call just for the minutes. So President Morgan.
Yes, yeah.
Excuse me.
Yep, that's-
Vice President Landry, Board Member Lindy, Board Member Harrison, who's online.
Yep.
Awesome, thank you.
Great, okay, thank you. Item number 2, approval of the October 16th, 2023 regular meeting minutes.
I second.
Great, all in favor? Aye. Okay, meetings, minutes approved, thank you. Item number 3, universal home visiting, Family Connects program highlight.
Thank you. We are pleased to present this tonight. It's been about a year since the Family Connects program was launched with ARPA funds, and we're happy to be back to be able to give you a little bit of a snapshot on where the program is these days and the progress that we've made, as well as some next steps. So thank you. Thanks for your attention on this tonight. It's been stood up remarkably quickly, in my opinion.
All right, next slide, please. Hello, Board of Health. I'm Felicia Kane, she, her, hers, Family Health Nurse Services Coordinator, and I'm honored to highlight some of our Family Connects accomplishments so far. Next slide, please. Before I dive into the Boulder County accomplishments, I'd like to point out we're in good company for Family Connects Colorado implementation. In fact, our work is so promising and important for Colorado that the governor has proposed in his budget Family Connects expansion. This would mean $4 million, if approved, would mean $4 million for 5 years and expansion into 6 other counties. In Boulder County, we are proud to be paving the way for statewide integration of Family Connects, and we look forward to your ongoing support. Next slide, please. Our current primary funding is the American Rescue Plan Act dollars awarded by the commissioners. Since then, we have hired several staff, including 6 bilingual staff, 2 of whom are mental health professionals. We have launched with Boulder Community Health, Vista, and Longmont United, plus Clinic and Salute are promoting the service. As of Monday, we have scheduled 386 visits and 307 have been completed. Of the referrals made for our clients, 76% were for mental health supports. As part of a demonstration grant, the Family Health Navigators linked families to resources and services. This system is now embedded with the Community Hub navigation team. Finally, the Family Voice Ambassadors group was established, and Aurora will speak more about the group next.
Hi, Board of Health. My name is Aurora Ramirez, and I'm the Community Alignment Coordinator for Family Connects. Next slide, please. So this diagram provides an overview of the structure of Family Connects in Boulder County and highlights the importance of ensuring that families have a voice throughout the program delivery process. We have a circle in pink at the bottom that represents our Boulder County families with newborns, followed by the blue circle representing Boulder County staff. And then finally, we have the orange circle that represents our Community Advisory Board, previously known as the implementation team. The CAB is a work group working under the Impact Executive Board, and we will be piloting the structure for the next 12 months. Family Voice is represented through the Family Voice Ambassadors, which is a co-created group that represents the communities that we serve. They're integrated into each circle, providing valuable input to help and ensure that the program is effective in meeting the needs of our families in our community. Next slide, please. This model is centered on the family and their parenting experience, providing a safe space for families to share their stories and enhance their voice as they participate in the implementation process. The Family Voice Ambassadors have provided valuable insight as parents of young children representing a diverse background of cultural diversity. They have contributed by providing feedback on the Bringing Home Baby Guidebook, which is being given to every single family that receives a Family Connects visit. And they have informed on best practices for community engagement and the implementation of Family Connects in hospital startup processes. Their diverse perspectives and lived experiences have been instrumental to ensuring the success of the program. And recently, they have received recognition from the commissioners at the Community Healthy Awards. Next slide, please. We also wanted to share a testimonial from Claudia, who was an involved family voice ambassador in Boulder County while she was pregnant. She learned about the opportunity through her daughter's child care center and was interested in contributing to a positive change in the community. She says, even though I already had 2 children before my baby, I started to feel very alone after having my 3rd baby. The nurse's visit helped me feel better. She gave me information that I didn't know, and she gave me information about resources in the community and confirmed that I was doing a good job as a mother. I don't feel visited by a nurse, but by a friend at a time when I needed it. Sometimes when we have a child, many mothers don't know what we need and what we don't know how to ask for help until somebody comes and offers help at home, like a Family Connects. Through the Family Connects visit, I was able to confirm that it is normal to feel alone or sad, and they have guided me on how to ask for help and where to find it. I will pass it on to Beth.
Thank you all. My name is Beth Garrett Myers, and I am the Infant and Early Childhood Mental Health Consultant for Family Connects. This role stems out of the successful outcomes of 5 years of mental health consultation with Boulder County Nurse Family Partner, and now we have expanded to Family Connects in Genesis. So maybe you can remember when you had your babies, or maybe you recently witnessed someone close to you having a baby. Becoming a parent is not always easy and straightforward, and it comes with a variety of emotions and stress, such as joy. Here is a list of some of the stressors that a parent might encounter. In addition to these, we also want to layer and bring to attention the additional demands, stressors, and oftentimes trauma experienced by families with a history of adversity, families of color, and families for whom English is not their first language. The Infant and Early Childhood Mental Health Consultant works to normalize and promote social emotional health and mental health in this perinatal period. Next slide. Recent data from the state of Colorado has shown that the 3 leading causes of maternal death in the first year postpartum are suicide, unintentional drug overdose, and obstetric complications. We know that for women of color, they have poorer mental health and health outcomes compared to their white counterparts. The good news is that 90% of these deaths are preventable, and a universal home visiting program has been recommended as a strategy to combat these risks. Next slide. Family Connects recognizes the importance of mental health, and we have created this role to further support families. This role is an innovation and is not typically found within the Family Connects model. There are 2 goals of the Infant and Early Childhood Mental Health Consultant. One is to support nurses' capacity to understand and respond to the mental health needs of families with a newborn 3 to 12 weeks. We do this through topic-based consultation, reflective case presentations, joint home visits, and individual RN consultations. We also provide direct support to families through phone, telehealth, and home visitation. We know that a child's health and global development is directly tied to the mental health of their primary caregiver. So we are always assessing and offering supports for the baby, the parent, and the parent-child relationship. We're helping families to understand and respond to their mental health needs, ranging from normal transitional distress and celebration to perinatal mood and anxiety disorders. So thank you for your attention, and I will turn it back to Felice.
Next slide, please. All right, our next steps for 2024 is to continue scaling up in Boulder County, ensuring ongoing funding, and further integrate the Family Voice Ambassadors as part of the infrastructure of how we operate. Finally, your support is critical. We humbly request that you sign letters of support to healthcare providers, to the governor for his proposed Family Connects budget, and facilitate connections with local hospitals as needed. Thank you for your time.
Great, thank you.
Can I just say a quick thank you to this group? This is Brooke Harrison. Sorry, I'm at a conference in Vancouver But I wanted to just say thank you. We took care of the children with special needs home visits. Our daughter was 6 weeks premature, and it was amazing. This program, I cannot support it enough. And I just wanted to say thank you. Kate Wicker was our in-home nurse. And yeah, this program was just, it helped us immensely. And you all are doing great work. So I just want to say a personal thank you.
Thank you so much for sharing that, Brooke. I will share that with Kate. Like Children with Special Needs is the other program that I coordinate. So thank you so much for sharing that.
Okay, I just had a couple questions. I work at Clinica and Avista. So if a patient gives birth at Avista, for example, or VCH, but lives in a different county, how is that handled?
For us in Boulder County, the eligibility is a Boulder County resident who gives birth at Boulder County Hospital. And that's so, if they're, so for now, we are not able to serve, like none of the sites like Eagle, Jefferson County, and Denver won't be able to serve that family. So if they give birth at Avista but are a resident of another county, we don't have that arrangement. However, if the governor's budget is approved, that will give us an opportunity to expand our reach within the hospitals we're currently working with, so that we can serve, get closer to the full client population or patient population in each of those hospitals. So right now, we won't be able to serve them. We can certainly provide, try to match families with other services and ongoing supports that might meet their needs, but we wouldn't be able to provide a Family Connects visit. Does that answer your question?
Yeah, I think that would be something good to include in the letter. If we sign that, because there are a lot of patients, particularly Adams County, but that deliver outside of their county.
Yes, absolutely.
Explore whether at least the counties that are running Family Connects programs could have some sharing agreements within a larger system, an MOU or something.
That'd be cool. How exactly are the referrals made? Because I can say, at least from my perspective, working, I don't know that it's 100% clear to all the providers. So I think there are some missed opportunities. And if you could forward that specifically to me, I can also disseminate it more widely.
Thank you. Yeah. So the way that it kind of depends on the hospital, on depending on who is making those, like providing those recruitment, like, or referral opportunities to families. For Boulder Community Health, it's primarily the lactation team that is talking to families at the bedside about Family Connects and scheduling. For Avista, we are trying to work with the floor nurses, but I think the next sort of strategy we're trying with Avista is working with behavioral health specialists who will be doing rounds on the floor and talking to patients about Family Connects. We're open to different ideas, knowing that, we aren't familiar with the inner workings of how, how each hospital operates. So we're looking at creative ideas. With our scheduling platform, families can schedule themselves, and that's so it doesn't have to be, recruitment doesn't just have to happen at the birth center.
I'd love to learn more about the referral process exactly. I think the lactation consultant would also be a better choice at Avista because the behavioral health providers are not available all the time and never on the weekend. And the consultants are at least there on Saturdays. But also probably a majority of referrals would come from Clinica patients. And Clinica, as you may or may not know, just eliminated their home visit program. So
Yeah. Yeah, I'm certainly, unfortunately, aware of that. And so, oh, sorry. Go ahead. Did I interrupt somebody? No.
Oh, I was going to agree with Landry that I think the lactation specialists are a better target at Avista. I think that they often assume that most of their patients are not from Boulder County. And so I think it was just sort of by luck sometimes that they make the recommendations. So the lactation specialist might be a good route there as well.
Yeah, we've been working pretty closely with Christina at Advent Health to kind of make those connections. So yes, we can continue to explore that. That was that opportunity as well. But in terms of being able to serve everybody in Colorado or, other counties, I know that once we are a certified site, it's going to be a lot easier. That takes a few years and it takes, meeting key performance indicators per Family Connects International guidelines. So that's the other factor to consider, in sort of how we're unfortunately limited on who we can serve at this point in time. But thank you for your questions. I'm happy to share more information to the board on recruitment.
I just had one last question. How are the outcomes of your visits kind of communicated back to primary care providers, or are they anyway?
Oh, that is a great question. So one thing, what we do as a standard is we have within our Salesforce charting system a kind of sort of an after visit summary. They're called clinical care reports, and we do send those to primary care providers or the maternity care providers. With consent. And we do send that as a standard after the visit.
Thank you.
If I could say just one last thing, thank you. I just wanted to call Brooke out. Thank you so much for what you said. Both Kate and Natasha, who are the CSN nurses, are also trained in the Family Connects model and do Family Connects visits. And one of the kind of bonuses that's been happening too is a lot of times when the nurses go to a family, sometimes the kids who are 2 or 3 or 4 years old in the home may have some developmental concerns. So we've actually increased our referrals into the CSN program as well. So it's kind of like a holistic family approach. And we've also found that sometimes the non-delivering parent, the other parent, also has some mental health concerns and they get referrals. So it's not just the birth parent who's being served, it's kind of the whole family. So
Thanks, Daphne.
thank you for having us. We really appreciate it.
Yeah, I have a question. I just second that I think this is such a needed program. It's been disappointing to practice in Colorado for a long time and have so many patients who aren't eligible for nurse-family partnership, right? And then not have an alternative for sending them for extra connections. And so I think this is really needed. And I currently practice in a county that this is not available to most of our patients. So I know I'm like, I want it everywhere, in all the counties. And I think we pointed out about the maternal mortality issue that 90% is preventable. And I think I would add to that a majority of it happens in the postpartum period as well. I think even more important that we're connecting these programs.
Thank you, Amber. So appreciate that. And ACC 3.0 has is also going after this. So not only the governor's budget, but there may be some opportunities for, because the goal is to roll it out Colorado wide. So hopefully. Thank you.
Yeah, and I mean, so I think this is so wonderful and needed, and I feel so privileged to have this available in Boulder County. We've been talking about budget, how do we sustain budget for this program going forward, and I know, so we're fully funded for 24 from the ARPA funds, partially funded. And what happens if the governor adds that money? Does that fully fund for 20?
I don't know yet what the allocation is going to be, but 10 counties, 4 million a year. We're hopeful that if we even get a tenth of it,
Yeah.
that will help us. And then we have MCH money. And then we have, with the Medicaid, 2025 is when, the home visiting code hopefully will open up. So between the patchwork of things, we are extremely hopeful. And then we'll of course ask for grants. Part of what we're trying to do too is track the outcomes so that we can work with HHS and hopefully get them to fund through the 1A dollars. But we'll see. So many strategies are underway.
Yeah, and because the ACC providers also have grant funds, right, that they distribute for community programs. I don't know if this would be a fit.
They do. I mean, CCHA helped us fund some, but then those dollars, anyway, that's a rabbit hole. We don't,
Okay.
probably is,
Yeah.
but yeah, thank you for that question, and it is on our radar.
I know it is. I know it is. Just however, and I'm glad, thank you for being very specific about what we can do to help in terms of. writing.
We'll ghostwrite those letters for you.
Yeah, great. Because I,
That's what I was gonna add.
Right.
Yeah, do that.
yeah, I think, you know, the board is happy to sign on to those and support and advocate as we can for sustaining funding and just, again, acknowledging how much money this saves the system.
Yeah.
Right, so I think that's really important to emphasize, and you all do that, so.
Well, and I do wanna say, Landry, your offer to advocate with the workflow is huge. And then Amber, you reached out to your contacts and helped unstick some sticky stuff, you know, like, so thank you. That helps when you guys help us use your personal connections. So thank you.
Well, thank you to, and I just want to make sure, no other questions. Thanks to the staff for doing the work and then sharing this presentation with us. So thank you. Okay. Next on the agenda is item number 4, the naloxone standing order update and approval.
Yeah, come on up.
Hi, everyone. My name's Georgia, she, her pronouns. I'm the harm reduction program manager for Boulder County Public Health.
I'm Alison Bailey, she, her, hers. I'm the program manager for the Community Substance Abuse Prevention and Inspired Youth Connections program in the Community Health Division.
So we here today to request an update on our standing order because our programs are expanding. Unfortunately, there's more need than ever before to provide naloxone in various community settings. So it's got size. So yeah, we can go to the next slide. So opioid overdoses are the leading cause of death in the US for people under the age of 50. So it's actually the leading cause of death, not just accident death. It's the leading cause of death. Naloxone is highly effective opiate antagonist that reverses overdoses. You all know about that. And Boulder County Public Health works to distribute naloxone to people who are high risk or have difficulty accessing it. Next. So our harm reduction program, the Works Harm Reduction Program, has given out 1,737 kits in 2022, reaching over 500 people. We've had 83 reports of naloxone being used to successfully reverse an overdose. That's very unreported. It's just what comes back to us. We know that a lot of people, more people are being saved with it. We've conducted 54 trainings. Actually, that's now up to 72 trainings since we put the slides together for over 900 people in 2023. And that's mainly professionals. We also provide individual training to participants who come into the program. And they're all professionals who work with people who use drugs. So housing, some of the home visitation programs, just to be prepared and ready to provide that.
And so why we're here this evening is to request approval of expanding the standing order. When the standing order was written, it was written specifically for the Works program and named the Works as the program. So in working with Eliana and Jordan and County Attorney's Office, the suggestion was to expand that to cover all programs at Boulder County Public Health. And so 2 in particular that we are looking to increase naloxone distribution through is our Substance Use Advisory Group, which is a collective impact group that works to bring folks together across the substance use prevention spectrum. And that group does community outreach events, different community places across the county. And then also we're starting a new project where we'll have a youth naloxone access program specialist. It's going to work very specifically in the youth community. The Works has worked really closely with the adult community for a long time, and we're looking to expand to work with youth. So because both of those live in community health, which is a different division than Georgia's division, we're requesting your approval to expand the order to include all of public health. The other thing that we have as part of the update, it's expanding to all these programs, but there was also some updated CDPHE guidance around more precautions and a follow-up requirement. All things that we currently do, but also updated the language to match the CDPHE guidance.
Yep, so Dr. Belknap is also online, so he's the final like signatory for this since it is through our chief medical officer. So with the board's approval, I will work with them to actually have the standing order updated.
Yeah, thank you for the kids that came to clinic.
Oh, okay.
Thank you. I think it's great that they're just out and available and patients can just freely take them at any time. So
We're working on vending machines too.
that was my question. I just read.
Mental Health Partners also has kiosks that we have kind of a working group that's implementing that. Our vending machines are funded through opioid litigation funding, so we're working.
A quick question, since you mentioned the funding for the vending machines, how is a lot of the naloxone is distributed? How is that funded? Is that federal dollars or is that our own county dollars that go into most of it?
What we get currently is through the state fund. It's a bulk fund. They're facing a fiscal cliff mid next year. So we were going to be putting some of that funding into the opioid litigation funding request. Just in case they don't come through and renewing that, which is possible. But they've been fantastic. Fentanyl test strips and Narcan, and they had almost no limit because they had some supplementary funding. So many community groups that we've trained have been able to access them directly. They just apply directly and then they set up their own standing orders. It's been pretty amazing. The state's pretty great.
I just want to add also that I was on a call today and the state, local public health agencies are aware because the fiscal cliff hits everyone. So I think there's a lot of legislative efforts to increase the bulk fund to make sure it's available.
We'll obviously let the board know how we can help with that as well.
We may call on you for that. Thank you.
Can I just ask an educational question? Is there a preventative component to this program, or is it more about the administration rather than, is there any kind of coaching or anything like that going on along it?
Well, so we all work together. There's the preventative, I don't know if you want to talk about CSAP, but we all work together. But are you saying within the harm reduction program?
Yeah.
So we do a lot of education around overdose prevention. And there's things that we, teach people about that. So, there's a few statistics like, people who come into harm reduction programs are 5 times more likely to go into treatment. We work closely with the jail because people are 100 times more likely to overdose on the way out of jail. So we've got packets going out as people exit. We actually fund MAT treatment in the jail and a position there, and our team goes in there and does education. So we do a lot of prevention education. So our goal is HIV, hepatitis C, and overdose prevention, but because of the number of deaths, HIV, we've had 1 case in 3 years. So we're doing a great job. It's working. But overdose is really the big issue now. So we're doing a lot of education around sort of people have shifted to smoking versus injecting. That's reducing the risk of overdose. We do a lot of education around that. So there's a lot of education that goes along and also support services so that we've created the services in such a way that people, when they come in, and they want to talk when they're ready to talk. And we have a case manager now. So we're doing a lot of support services for people who are already using drugs. And then we have the prevention side of things.
And Longmont, like the Recovery Cafe.
Oh yeah, so we also fund Recovery Cafe, and we all work together and do education together. So we just meet people where they're at and depending on where they are. So Recovery Cafe provides amazing services, and we network with other recovery services.
And those are people who have gone through treatment and it's kind of a peer-based.
There's a big peer, that's all peer. Yeah. So, yeah.
And many opportunities and touch points to also refer folks for treatment when they're ready for that.
Many. And we're just getting a lot more. We actually have set up 2 rooms now so that we can spend half an hour with people if they need it. And that's when you really get that contact and they're ready to, it's not when they're in and out quickly like that. You don't get that really conversation with people. And we just do a lot of education around, we do HIV testing. So we're updating people on the status, and there's always a behavioral component of education with that. We're always talking about behavioral stuff, yeah. condoms flying out the door. Everything. So we, and our team is just very passionate, and our participants are amazing, like, in terms of, and also syringe disposal. We do syringe litter walks, so we have almost, I think we picked up like 48 syringes last year, and we do weekly walks. So our participants, they go out with all the different size syringes, and we don't really have a big issue because and again, education is around where can you dispose of, bring it back here, this is how you do it. So there's a lot of components. Come and visit us if you want to just visit the site, but we're doing it all the time. So education is a big part of it. Big part of it. And also warning people about what's on the market. We work closely with the DA's office and the sheriff's office, the drug task force. So when stuff's coming in, xylazine, now we're giving out wound kits, and we do a lot of education around that. We're giving out xylazine test kits. So all of that is preventing, it's tertiary prevention because people are currently preventing wounds. We're doing a lot of wound care education because xylazine is different to the other wounds. So it's be kept wet and everything. So tons of education. Our team is just like amazing.
And I just want to say, it is an amazing team,
Yeah.
and it's the third oldest in the country, third oldest syringe access program in the country. And that we have a lot of support from different partners. And I would say the key that I see is the relationships. So the staff have really strong relationships with participants so that there's a lot of trust. And that trust is really, really vital for helping people to move out and get treatment or supporting them where they're at.
Yes,
So
yes.
I
Our referrals have gone way up.
Yeah.
Really changed the way we having a case manager, but also cross-training the whole team.
Yeah.
We have one case manager, but can't be there all the time. So really getting, making connections with all the services. And now we have a bilingual, bicultural. She's like crazy connected with everyone. She's like, oh my God, all these people. So it's made, we also got a consultant to come in and work on Hispanic and Native American outreach because we weren't doing that, as well as, we were 1.5 people, now we're like 6 staff. So we've really grown the program to meet the need. So Spanish speaking.
Yeah, I'd love to come visit.
Yeah, absolutely. And it's really interesting. People walk in and they're like, oh, this just looks like a regular clinic office. We're not down the stairs back, like we're not ahead. It's a totally accepted program. It's wonderful. It's a really great program. So,
And the last couple of years working really closely with Allison. And
yes, we're working really closely together. Where is it? Well, we have different sites around Boulder. We have BCAP has some site, Mental Health Partners at Airport Road has a site, but the Longmont site is really where you see it in its full, the way it really should be delivered. There are limitations at the other sites on, access. I mean, not accessible, but the best practice model is when people can come into it in a private office and talk. They need to talk. Because that's when they move to that next level of like, I'm ready to get off the streets. I'm ready to go in treatment. I'm ready. And that's only happens in a safe environment. And we're doing that with now 2 offices. We only have 1 office. So we're really busy and we have an amazing team. So please come.
Can I ask about partnership with the
Do we-
university?
We work, so we have a fentanyl working group that we work together with, and we work closely with the university to respond to all the different things. And so we've supplied them with a lot of supply. We have a great relationship with them. They have a great program on site, and
Okay, so they have their own.
they have their own
separate
program, but we work really closely together. Anytime we have like the xylazine updates and stuff, so we developed a presentation. They came along, they know what to incorporate. They're actually looking at vending machines too. They probably won't have syringes, but they might have, pregnancy test kits and other things in there, depending on, what they decide to do. But we're very closely, don't we, with them on the fentanyl. Every time, also when there's an outbreak, we have an outbreak response. Outbreak, that's not the right word.
we have an emergency response
plan. So if we've had a number of overdose deaths in a certain period of time, we all come together, and that includes the university, to come up with a plan for communication. It's our emergency response manager.
Yeah.
Is amazing.
The plan really helps to align all the key messaging. And what the university has shared with us is that it helps for parents to know this is a community problem. It's not a university problem. And I think it takes that burden of stress off of them when we all do it together.
They're amazing. When they ran out of stuff during COVID, we delivered fentanyl test strips.
And Allison, do you want to talk about prevention?
Yes.
Talk about all the.
Can I ask a quick question? I'm just curious, like, so I think that especially when safe injection sites were on the legislative agenda last year, there was a lot of public pushback. And I'm curious if it is tracked and if it could be made available, the percentage of unique clients that are in the Works program that enter treatment. I don't think that that is currently publicly available, but it could help to garner some more public support for this program.
And we don't have that, we don't track individual identities. And that's why people come to the program. So yeah, we're not a research study, we are an anonymous program that, for that reason, people come in. It would be good, I mean,
Well, it's hard to track success though then, right? Like, because if you do track the number of unique clients, so how do you, what are the measures of success then? I'm just thinking about to be able to gather more public support, especially going into the next set.
University do that. You know, if we had some kind of, study that could track that, but we don't have the capacity now. People would have to voluntarily enroll in that and disclose their identity and stuff like that. So you're right. I mean, we rely on other research studies that show that data. Unfortunately, we don't have that data. But there's so much evidence for that, and you can probably tell with my accent from Australia, and they've been doing it for 30 years there with great success, and that has been research proven. So and it's been proven in other places. So our individual program, we could track it if we had extra money, but I don't think it would add significantly to the research that's already out there that shows that it works.
And we do have some metrics like.
We have good metrics.
Yeah.
Yeah.
Our rate of Hep C, our rate of HIV in
Yeah.
Boulder County significantly lower than other counties. There are outbreaks in places we don't get the outbreaks here.
You track number of referrals?
Yes, we do. Yeah. And time for referral. We have all that information.
I thought it was pretty compelling. Didn't you guys presented to the Boulder City Council last year and you got unanimous support for the safe injection support in the legislature, which I was really surprised by, honestly, that across the entire council, right? They all ended up supporting that. Am I remembering reading about that correctly?
So I don't think we presented to them, but I did have individual conversations with certain council members who had questions.
Yeah.
And
They signed a letter in support.
They
they did, but they had a council meeting where they decided whether they were going to support it or not.
Yeah.
And in the end, what I found really positive was the council members all seemed to recognize that this is probably a safer alternative than people being out on their own, and the death rate would actually go down, which is what the evidence has shown. I think, the conversation we had with them was around, it's okay to have some guardrails. It's okay to ask questions. It's okay to get community input and all of those things. But in the end, I think they were very supportive.
Right. Because that first legislation was around individual, local jurisdictions being able to decide.
Right.
And this round, the legislation did not say that. It was allowing for pilot programs. So it didn't require local council approval.
But the governor has put the kibosh on.
Yes, yeah, no, I saw that too. So in terms of expanding access and training, just as a non-medical provider, is there a risk of accidentally giving someone naloxone that doesn't need it, that isn't?
No,
Okay,
great.
so
You could give it to someone who's having hypoglycemia on the street.
great, so that,
And there's no age restriction. You
I
can
know
go
age
over
restriction,
anything.
yeah.
That's-
No, with,
Oh, I didn't know about the.
they often need multiple doses, so you really need to call if you ever use it. And it's very scary because someone will go from being dead, appearing to really angry and the worst pain of their life and very, very mad at you. Yeah.
I also
It's
saw,
very, very scary.
Dr. Belknap, you had your hand raised, and we have about 3 minutes.
Yeah,
sorry.
And Allison has some share.
yes.
Yeah,
Did you
thanks. I was just gonna comment quickly, and I'll try to share it. There was an article published in the JAMA journal just about 3 days ago on an evaluation of the overdose prevention centers in New York City and the impact on crime and disorder, which is one of the concerns raised that, oh, you put one of these in an area, then that's going to attract more crime. And the result was that it didn't. And so, I think, as was mentioned, there's a lot of evidence for this. The arguments against it are not evidence-based. They're mostly fear-based. And so to the degree that we can continue to support the best evidence and try to help answer the questions that people have. I mean, I think as Indira pointed out, we want people to ask questions so that we can try and answer them with evidence. So thanks.
Just briefly, with the CU question and the prevention question with our, the youth naloxone access position is we're going to take the success from George's work and really bring it to young people and add, continue the harm reduction training and then work with our partners at CU and some other folks to think about what's a comprehensive presentation for young people that includes the administration of Narcan, includes harm reduction, and then includes some other pieces that are more relevant for young people. Because a lot of the training that George's team does is really focused on people who are using drugs at the moment, which that is definitely happening with our young folks, but we're also looking at that prevention aspect as well, and empowering young folks in our community to know what they can do, how they can have conversations with their friends, and how they can be prepared. So that's a lot of what we're excited about with that youth access position. And then just briefly, some of our other prevention work in the community substance abuse prevention program is really focused around working with our community partners, developing youth leadership to have community-led solutions. And I know our division manager, Heather Cray, is going to talk a little bit more about that later on tonight.
And the school districts have naloxone on site, is that right, in all the high schools? And then how are they doing?
They have teams that are trained at each school. I think St. Brian also has that now. So they have teams that were trained. So they have a response team within, not just the nurse. The nurses led the way, and then they have, they have, I would imagine, multiple kits in the school. That's what
It's a gap.
Yeah.
Right, so the gap is that the schools have response teams, but they don't hand out naloxone, which is okay, right? Because that's not part of their, strategies. If they're there to educate, so we're okay with that. But it is a gap, which is part of why this youth group is really important, because we still need to make sure that youth have access.
Right, that's what I'm trying to get at, right, is how are you accessing the resources?
And that's exactly part of the goal of the position is to look at that distribution among youth and find where are some trusted places where youth identifies where they want to go. And then, as Georgia talked about, working with them to get access to the bulk fund, to get their folks trained so that they can be something that then that group is owning and maintaining with us providing technical assistance as needed.
Thank you. Yeah, really, again, it's really important work for our community, so appreciate it.
We'll need a motion in a second.
Oh, right, yes, thank you.
Motion to approve the
I second.
Sorry, it's okay. Naloxone standing order. Yeah.
And I second that.
Okay, all in favor? Aye.
We need an invitation.
Yeah, yes. The order has been, the updated.
Flowery or agree then?
Okay, thanks, Brooke. Updated order approved, so thank you. Yeah. Okay, item number 5, public health improvement plan, vote for approval. This is, I know we had the presentation last month.
So tonight,
Rachel's on?
go.
Yeah.
Move on up. Rachel's leading the show. Great. Elise and Rachel are here tonight. We're not going to do another presentation, but we did want to review the questions that we received between the last Board of Health meeting and now, so that you can all see those responses. We even got one since the director's report today, which is great. Thank you. And then we would love to move forward to a vote, if that sounds good. Thank you, Rachel.
I was gonna say, am I good to go? All right, good evening, everyone. My name's Rachel Mintel. I use she, her pronouns. You saw us last month, as we talked about, where Elise and I presented on the Public Health Improvement Plan and our Community Health Assessment. Dahlia, if you want to go to the next slide, please. Thanks. So as Lexi said, we aren't going to do a full presentation tonight. We're just going to kind of touch on the questions that were provided to us and our responses, just to kind of ground us and refresh our memories a little bit, since it has been a whole month. And I'm sure you were not all just poring over the community health assessment and FIP for the entire month. Last month when we were here, we did share the finalized documents with you for our community health assessment and improvement plan. We also kind of outlined what the process was for developing those documents and some considerations that we had when developing, and some considerations for implementation. We talked about some next steps with our FIP, and then requested any questions that you guys may have after reviewing the documents, so we could provide some of those responses. So Dahlia, if you want to go to the next slide, we're just going to jump right into the questions. Some of these responses were provided to you via email, I believe. So I'll kind of touch on what these responses were. So the first question, great question. What would success look like for our public health improvement plan? So on one level, we will be identifying indicators, some high-level indicators around mental and behavioral health. We are planning to work with the county's behavioral health roadmap on identifying some shared indicators, since we're working towards the same goal. But we also acknowledge that we will have some indicators that might be more specific just to public health and what our role is in mental and behavioral health. Some of those sources are listed on the slide there that we'll look to identify those indicators. County health rankings, Healthy Kids Colorado survey is a really big data set for us that we will look to try and find some of those indicators. On another level, we will be working to identify measures, process, output, outcome measures, some of those more short-term or intermediate measures for our objectives in the public health improvement plan. And this is going to be part of our strategic plan. So if you remember, the mental and behavioral health goals from our public health improvement plan are also our mental and behavioral health goals in our strategic plan. So as part of our agency strategic plan, we are developing a monitoring, evaluation, and learning plan. Plans upon plans. And part of that will be identifying those measures and tracking and reporting out on those measures as well. Next slide, please, Dahlia. So that leads into the next question of how is that going to be made available to the public? So back to those high-level indicators, those are going to be incorporated into our data dashboard that's being developed by our public health epidemiologist, population health epidemiologist, Michael Wu. And then those other measures, those more short-term and intermediate measures, those are going to be communicated out to the public again with our strategic plan. The details are still being ironed out, but at the very minimum, our plan is to develop an annual report on our strategic plan, which would obviously include mental and behavioral health measures, and that would be made available to the public as well. We do invite, if you have any ideas as the board, if you have ideas on how we can share that with the public, best ways to reach the public with this information, we're open to that feedback as well. Next slide, please, Dahlia. All right, this question is asking, why is promotion advocacy for addiction treatment not included in our public health improvement plan? So as it says here on the slide, we do support diversion to treatment, but it is not our primary purpose of our programs. So this is an area in mental and behavioral health where we don't necessarily play a leading role. We play that supporting role by supporting other programs and other agencies who may be better positioned to make those referrals and to support that treatment. Not to say that's not part of what we do, but it's not necessarily in our swim lane compared to some of the other agencies where it might be more in their lane or in their scope of work. But again, as it says on the slide, advocacy and promotion are included with our policy work in partnership with the county. And if, Lexi, if there's anything else you want to add on that last question, I'm happy to turn it back over to you. I'm not quite the expert on that portion of our FIP.
Just to say that, it's really important as stewards of county funds not to duplicate other groups' work, and we try really hard to make sure that the work that we're doing complements the work and doesn't overlap too much in their spaces unless there's a reason for it, unless there's something that makes sense. And just recognizing that there's an enormous amount of work happening in the MBH space right now and a lot of momentum for a whole bunch of groups, even groups that haven't traditionally done it, to step in and to have dedicated funding for treatment and to have dedicated funding for navigation. We feel like community services, other groups are better positioned to do a lot of that work, but we absolutely make connections opportunistically in our own.
Lexi, can I add something there really quick, if you don't mind? Yeah, I think that's spot on. And, you know, we talked a lot about, before we even jumped into the space last year, we talked a lot about what is our swim lanes, right? What does that mean? What does public health do really well? And we talked about, like, what do we need to step into more? What do we need to step out of in different spaces and things like that? So I think this discussion has been ongoing for quite some time. And on top of that, this also comes from our feedback from the community. You know, we did community engagement spaces, and this is what the community also said to us in the space. And so that also has informed some of these decisions.
You guys might want to consider, I don't know if this makes sense or not, but nobody will understand that narrative aside from you, right? So if we're like thinking about how we disseminate what we're doing here and helping the public understand that better, that's one of our goals. It might be helpful to wrap this in the broader narrative around this is how we fit into the broader ecosystem so that people understand what we are tackling and what we are not, because we're explicitly not doing certain things, right? And I think that would help.
So do you remember that it looked like a speed, it looked like a speedometer?
Yes, yeah.
And it was a spectrum from primary prevention all the way to treatment and recovery, and kind of had this piece right here is public health's wheelhouse.
Yeah, that's in the materials landed right now. Yeah, okay.
Yeah, I think that is a great point, and that is something that.
And Lindy. Well, I agree with Lindy. I think looking at this from, if I was a member of the community and looking at this policy, I would ask, okay, so now we go from early intervention straight to harm reduction, and there's no mention of treatment. And I know we've had this discussion before that it is not BCPH's swim lane to actually carry out the treatment. But I do think that if you are looking to get public support from this, a person reading this would want to see at what point are people referred to treatment. So at what point does BCPH say, maybe you should go into these other programs for treatment? And just reading through this, it seems like a very obvious missing piece to the progression. And I totally understand we're not administering the treatment. We don't want to step on anybody else's toes. We don't want to put funding into that. But at what point do we say, okay, here are some treatment options for you, and we defer you to these other partners?
I just want to come in defense of the team because it's actually there. I think maybe it could be highlighted more, but the connection with mental health partners and the community health centers, it is there. It is written out. Maybe it could be highlighted.
And it could be that comes from SAMHSA, and it could be to federal government academic. So we might want to look at a continuum that is a different visual that might help people to understand. Yeah. And I was just going to add that a couple of years ago, Brooke, to your point, the Substance Use Advisory Group identified people needing treatment and access to referral of services. And we actually at Public Health got the money to do that work. But that behavioral health hub, which was created in the county, doesn't live with us. It lives with community services because that's not really our wheelhouse. So we work really closely with these other departments across mental health work, so we don't duplicate services. So that community hub is now serving for people who want to go to treatment, who need a therapist,
It's supporting Family Connects. It's supporting like any kind of referral system is going through that hub. But it doesn't live here anymore. Even though we were the architects to help get the funding for it, we recognize it better lives in a different department.
It feels like some of the, Brooke and Lindy, what you're expressing is like, if you were a member of the public reading the public health improvement plan, would you be confused about why that's missing or, not emphasized enough? And I do think it brings up a good question about who's the intended audience of the FIP, right? Like, what are we using the FIP for? And the FIP is a required document by the state, and it should be guiding a lot of our, strategy and coordination with other programs, but it's not necessarily a broadly distributed public document to my knowledge.
Yeah, and that's, if I might chime in just really
Yeah.
quickly, I mean, I think what you bring up is an excellent point, and I do not think that this document is going to be the prominent face of this work in the community. One, because I think it is a very lengthy document, and having something that is much more digestible, also at a more generally accessible reading level, even, I think is a consideration. I'll let you finish. Go ahead.
Yeah, no, I mean, I just think that like, I think what you're bringing up, Brooke and Lindy, is important for us to think about how do we communicate what public health is doing and how it is coordinated with all the other things, but that I don't think that the FIP is intended to be sort of something that we lead with or that a lot of community members are going to be seeking out. So I think, I don't know, if that helps.
No, I agree, Morgan. I agree that the document isn't what they're going to read. I'm more thinking about what will be the public facing display of this plan that people would access. Because people are looking for, treatment's getting a pretty strong emphasis in local, county, and state elections now. So for the department to put forth its best face, there should be something outwardly facing that says, this is how we deal with treatment. Even though we don't own it, it's not within the department. This is where we make referrals and things of that nature.
And really quickly, I think this is what you were about to say too, Lexi. Part of this as well is recognizing that our FIP is intended to fit within the county's broader behavioral health roadmap.
Yeah.
And so the intent is also that that roadmap is intended to clarify some of that to the broader public, just what you're describing, Lexi. That's been a lot of these conversations as we work for alignment with our FIP and the behavioral health roadmap, is being very explicit of public health swim lane is that our primary focus is that primary prevention, early intervention, and harm reduction work, and having that be a part of that broader narrative. But absolutely agree that we do play a role in that narrative too.
I think what the behavioral health roadmap will show, Brooke, is a really holistic perspective on how we're all trying to work together and how we fit into the full spectrum.
Yeah.
Part of what the implementation plan work will be is to make sure that we are reaching across the full spectrum, and if need be, make adjustments as we go forward. And so even if that's not as explicit in the FIP, recognizing that we do have the work in our programs, that will flow through. And we also want to see the folks whose primary work is to do referrals and make sure that our programs are connected with them so that we have that that flow.
Yeah. I just also want to say that, there's going to be a communications plan for this as well, right? That's going to be facing the community, looking on our website, but a large part of it is connecting with that roadmap piece. But I think, the point is we can build something that gives people that, what those connections. And I think that we could do that. And we've been toying with different graphs and different, graphics, not graphs, and things like that. And, because I will say stuff no matter what, but, the US, sort of the gringo model of this doesn't look at prevention that much as other spaces. And I think that we have to recognize that. And so I think there's a little bit more burden on some of the comms piece with that. Because people, when you talk about public health, they think about treatment, right? And they don't realize sort of the importance of that prevention side of the work that we're looking at, or the harm reduction space.
And that when we succeed, you don't notice it because you don't see the problems in the community. That means that is.
People might notice at this point, like.
Well,
Yeah, people will notice.
Generally, that's the burden of public health. Okay. Do we get through next? No, one
Yeah,
last-
unless there's any other questions, I think Rachel's one more slide, yeah.
Okay.
Yeah, so at this time, if there are any more questions, but happy to discuss. Otherwise, we would request formal approval of our public health improvement plan from the Board of Health.
Great. So I missed last month's meeting, so I pretty confident I missed it. In terms of the KPIs, the things that we're tracking against, how are those showing up, just to confirm my understanding, are those coming through the strategic plan? Okay, I just wanted to make sure I understood where those are coming. Okay.
Yes, and as I think as Rachel mentioned a little bit earlier, part of this is trying to keep in sync with the behavioral health roadmap process. This has been kind of one of the ongoing discussions is what are those overarching goals as part of the roadmap, and therefore where does public health metrics that align with our FIP and align with the roadmap, where do those feed in? And so this is kind of, as I think Rachel alluded to a little earlier, and we talked about last time, is kind of an evolving conversation, but that is ultimately the goal that we are working towards, is keeping all of those pieces in working together seamlessly and smoothly.
And in certain cases, there will be a from and a to, meaning we're going to try to do X, like very quantifiably. Is that part of this? Just so I understand kind of the level of.
Right now, most of what is in our FIP is primarily those specific activities. So what are the efforts that need to take place in the first year? As you will see,
Like processes versus.
a lot of process metrics, but ultimately the goal is to tie those two larger overarching indicators. We do have, as part of the behavioral health framework that was developed by BCPH staff back in 2021, there are these kind of overarching indicators for the framework overall. I'm sorry, I should say there's overarching goals for the framework overall. There aren't necessarily specific indicators tied to those, but that is kind of where we're looking to have that clarification. And again, where we're hoping to have that tie into the roadmap as well. We're all, like we said, having these ongoing conversations of what does success look like overall for the agency? And then based on what we have planned and the areas of focus we have planned, what are those indicators for success? But yes, right now what we have is primarily process focused.
Okay, and I assume that like as you move down that timeline, it'll become more rigorous from a quantifiable perspective, meaning it's going to take some time to set things up.
That is the
The
intent.
process, the focus at the beginning, but you're going to start to move to measurability over time. Is that generally?
Generally, we would say so. I think we will probably always have some fairly process focused things of standing up X, Y, and Z. I mean, rolling out I'm making this up a little bit, but this is something that we've talked about, right? Like rolling out an anti-stigma campaign, right? But ultimately there are quantifiable metrics that can be associated with that, such as reach, right? And so ultimately that would be what we are interested in working towards for sure. Did that answer your question or?
It did, yeah.
Sorry, go ahead and do it.
I just want to also mention that the metrics may not get better. The number of works participants may not get better because, we're pulling people out of the river. And until we as a community go upstream and start addressing all the root causes, then we may not see some changes. So I appreciate the conversation about metrics, but I also am a little nervous to say like things are going to always get better. We're going to do our best, but there's some serious inequities and housing and all these other issues that we have no control over that really impact what we see in terms of substance use addiction and mental health challenges that until we address those, we probably we may stabilize.
Yeah, but I think we could.
But we may.
I think there's some methodologies though where you can control for things, right? Like, I hear you, and I think there's ways in which you can measure certain things.
Yes.
And hold a standard that something will improve, right? But
yeah,
I
like
totally understand.
like our
what you're saying.
over.
You have to measure the right things, and you have to control for the things that you.
And a good example is our overdose numbers are getting, I think they're better in Boulder than they are in the rest of the state. And I think that that's partly all this naloxone work. So I think there's some, exactly right. There's some measures that we can look at, but we have larger societal issues that
that we are not going to cover tonight in our meetings. Appreciate. Yeah.
I moved to.
Yeah, so, yeah, so thank you, but I think, Lenny, there might be an opportunity to weigh in on when the strategic plan.
Yeah,
That's great. Great, so we have a motion to approve the 5th. I have a second. Great, thank you.
Thank you.
Favor of 5th approval?
Aye.
Aye.
Hi.
Thank you, then 5th is approved. Thank you for your work on it. Good work, team.
And Brooke, we will make sure to raise up some of the good points that you made as we represent the MBH work in our strategic plan.
Yeah.
And we think you'll see it very clearly when we get to the behavioral health roadmap.
Good, yeah, I think that'll go a long way with public buy-in and perception.
Excellent. Okay, thank you. Item number 6, health and racial equity and community engagement introduction.
Terrific. So tonight we have Kevlin Ma, our health and racial equity. Thank you.
I'm gonna stick around.
Sorry, just a quick, thank you so much.
Yes.
Rachel, Kelly, the team, Dave that worked on this, really appreciate all your work. This is a wonderful accomplishment.
Yes, it's a huge undertaking.
So tonight we have with us Kevlin Marr, Health and Racial Equity Manager, and Heather Crate, our Community Health Division Manager, and one of the original founders of our health and racial equity work at Boulder County Public Health, to talk a little bit about the connection between health and racial equity and community engagement, and why those are connected together and how they feed each other, and how it's really hard to make strides in health and racial equity in a community without doing community engagement. And part of the reason that we want to open this conversation is because, well, first of all, you're going to see community engagement as a strategic priority very soon, very, very soon. But also, I think it's really important for the board to have a little bit of insight about kind of how we're trying to approach community change processes, and kind of where our values inform our practices, and what you would expect to see in that space. So I'm going to turn it over to you two. Thank you very much. Yes.
Hi, Board of Health and other guests. Can you hear me okay?
Mhm.
Okay, awesome. So hi, I'm Kevlin, they, them pronouns, Health and Racial Equity Manager, and thank you, Lexi, for the awesome introduction. I'm joined with the awesome Heather Crate, who will be speaking in a couple of minutes, and we just want to give a brief overview to Lexi's point about how our health and racial equity initiatives are kind of in alignment and tandem to the community engagement strategy that we're trying to develop as part of our new strategic plan. So we're gonna, for most of the presentation, we're just gonna give you a brief overview and hopefully have some time at the end for questions and reflections, which I think is where we'll get really to like the meat of this. So in short, BCPH has a history of committing to racial equity and community engagement. We have a few examples as you've seen with family health. We have community health, which focuses on supporting young parents, LGBTQ youth, and substance use prevention. Environmental health monitors and improves living conditions across the county, including air and water quality. We're working on making sure our water quality response has an equity approach to that as well. CDEM has contracted with local partners and co-developed action responses to support testing and vaccines for COVID. And so that's just kind of the stuff we were normally doing. Obviously, we have a lot more than that. As you're familiar with the director's report, we also have our internal health equity coordinating committee, also known as the HEC. Several members of management team here and just people in the room are a part of it, which is awesome. It was established to further advance BCPH's mission to address health inequities in Boulder County. We know that as societies evolve, as more research comes out, that our equity and community engagement initiatives also have to evolve. So this work group is kind of tasked with identifying needs and gaps and also operationalizing our plan. So we have 5 major work groups: organizational culture and accountability, talent acquisition, retention, and career advancement, learning and growth, policies, procedures, and practices, and of course, community engagement, which we will be focusing on a little bit more today. I'll pass this off to Heather. Next slide, please. So Heather will be kind of introducing the community engagement spectrum, which is a great visual to kind of understand multiple arenas in which government agencies or institutions engage in community engagement and kind of where we want to be according to our vision. So I'll pass it off to you, Heather.
Thank you, Kevlin. Good evening, everyone, and Board of Health. Heather Crate, they, them, theirs. So you all received a little bit of information. Hopefully the spectrum doesn't look completely brand new, but this is one of a myriad of examples for defining what community engagement looks like or how community engagement can be approached by public health. This particular model is called the spectrum of community engagement to ownership from facilitating power. And so this model looks at 5 distinct stages of community engagement and sort of flows from this left to right approach of different styles and ways that we as an agency can work to engage with our community. So it's not necessarily laid out as, you know, the left of informing is less important as the right, number 5, to deferring to the community taking leadership. There are moments throughout our work as we work in partnership and to engage in community where we utilize all of these 5 approaches. And sometimes in the same project, we might utilize all 5. So the approaches involve informing the community. So this is where we're just sharing relevant information, consulting with the community to gather feedback, to maybe some deeper involvement where we're starting to have more conversation and the community is starting to inform planning, to collaborating with the community to ensure the community has a role in implementing decisions around programs, around approaches, around work, to some projects and work that involve completely deferring to the community, to community really running the governance, the decision making, having all of that power and authority in a project. So this is kind of the model and framework that we decided as BCPH really lent a nice picture to the type of community engagement that we do, the variety of community engagement. Next slide, please. So this one was mine, right, Kevin?
Yes.
Sorry. Thinking about why community engagement, why is this important to public health? There's a lot of different research into why we can't just do public health work in a vacuum. As the community health division manager, it's really especially at the center of all we do. So advancing all of our health and racial equity work really requires that we engage with community, that we especially engage with communities that have been harmed by government, by relationships in the community that maybe haven't gone well historically or have been oppressed by certain systems, that we listen to those communities, that they are solving the problems that they're facing and sharing that with us. Community engagement really leverages the resources and the inherent power and strength that our community holds. And it ensures that we're on the right track, that we're not just sort of dropping implementation or implementing interventions out in the community that we don't know how they might work or if they're wanted or needed by our community, and really allows us to focus our resources where they can be most effective and address needs that are important to the community. Next slide. So we wanted to share just a few more specific examples with some lovely pictures. Some of these you may have seen before, but these are just some examples of the type of work we do in different varieties along that spectrum. And if you had a chance to dig into that community engagement assessment, you could see that throughout our agency and every division of our agency, we are doing community engagement work. And the assessment that the board had a chance to look at allowed programs to do a self-assessment and define whether that was a consultation or informing or power sharing. But looking at the slide we'll start in the bottom left, this was an opportunity that our Healthy Eating Active Living program and environmental health was giving an opportunity for Boulder County youth to be engaged in a process and use their voice to talk about sugary drink consumption. The next picture is from a Pride event. So we were collecting information from the community about what they want to see. So we were consulting what kind of impact do you want to see on the LGBTQ community. Up in the top right is our vaccine team out at Cinco de Mayo, most recently this year, so engaging in particular with some of our priority populations. One of the things that I know I've talked with many of you about before, who've been on the board for a little while, is the fact that in our agency we hire high school students as employees. So that's one of the ways that we really integrate community and youth voice in directing programming. And then the last picture is from our To the Root or A la Raíz project. So you probably can't see it in the picture, but all of those little animals and different imagery have feedback on them from youth in the community. So these are just some of the ways as an agency. There's hundreds and probably thousands of more examples, but we just wanted to share some of the ways that we're already doing community engagement as we work to become more intentional in increasing that. Next slide.
Thank you, Heather.
Back to you.
So as we've kind of talked and as Heather kind of shared out on the spectrum, you can clearly tell that on the left side is more of that informational, consulting, involving a little bit. But we're attempting to move a lot of our programs or our efforts, especially in the strategic plan, more to that right side of deferring to. So that just doesn't mean you give them all the resources and let them run with it, right? It means having them being actively involved in their own discussions of their own health. And in order to reach that, there's this word, which is obviously very beautiful and very relevant to this, called power sharing. So for those that aren't familiar with it, this is a great kind of definition or use of the word by human impact partners. Of course, you can go into it in as much detail as you want. But power sharing means widening and shifting the circle of people involved in systems change and in centering people who are most impacted by inequity. So rather than us making the decisions on behalf of the community, they will inform us of what decisions they would like to see from us to better their health. So some key components of power sharing, of course, there's a lot and we can answer some questions about that. But a few that we're trying to focus on are: one, building and rebuilding relationships. We understand trust is a huge part of this. Government entities, public health entities don't have the best standing relationships with communities, especially those that are historically marginalized. So a huge component of power sharing is sharing trust and relationships. Of course, centering community needs as expressed by the community, like I just mentioned, developing the work together, even turning over decision-making to partners when we can, releasing the need to control all decisions and being open to unexpected needs, requests, and approaches. So essentially being adaptable, being creative. And then lastly, having an agreement on how to work together and manage our expectations. Because of course, we as government entities may believe the community is going to handle or react to something a certain way. They may feel the same way, vice versa, and make assumptions. So if we are building mutual relationships and trust, we can align ourselves to our work, our scope, and our expectations. Next slide. So these are probably acronyms or things you've heard before. So Community Power Building Organizations, CPBOs, and Community-Based Organizations, CBOs. Of course, there's a lot of institutions that have a little bit of overlap, but we really wanted to highlight these two because a lot of our community engagement work, especially as it relates to power sharing, will be focusing primarily on the first one of building strong relationships with them. So CPBOs, they're kind of tasked with advancing community transformation through organizing and changing power dynamics in communities and advocate for deeper structural changes. So these are the more advocacy organizations, kind of the ones that are tapped into the community about their needs, but kind of including their voice at the seat of the table about how we can move forward, giving them that power. Whereas community-based organizations are kind of aiming to connect and provide downstream services to impacted communities, whether it's vaccines, STD screenings, things of that nature. Of course, there's a lot of institutions that involve both, but we would like to focus our initial community engagement strategies on the first one. Next slide, and I think Heather has the next one.
Thanks, Kevlin. So as far as how we plan to take the next steps with institutionalizing community engagement, as I stated earlier, we've been doing community engagement for a long time. But we are looking at ways within our strategic plan to set clear goals and objectives around some really specific steps with community engagement. So we have a community engagement work group that's been working to really define how we intentionally do community engagement across our agency. We identify community engagement as a key budget priority, and we've been working with partners around alignment and feedback on what we can do better, how we can better support them as public health, and leveraging all of their expertise and voice. We're building out and planning for alignment and collaborations both internally to the county and externally. So we, several of us had been meeting with different leaders across the county around a vision for community engagement and what that looks like, how we define community engagement, how we're doing community engagement. So some of that work will be presented as a more formal vision. Kevlin and myself are participating, and Lexi, when she's able, are participating with the CalFO Community Engagement Work Group. So that's with public health folks from across the state who are engaging in community engagement work. It's a lot of engagement. And then we participate in the Metro Denver Public Health MDPH Community Engagement Work Group as well. We have staff who attend that. And we're partnering with some of our power building organizations like out Boulder County, 9 to 5, and others to really, again, leverage that power and community engagement work.
I mentioned that the CalFO's Community Engagement Work Group is housed within their Public Health Transformation Initiative, which was started before the pandemic, but kind of got off the rails. And as they regroup, this issue kind of is centrally identified as the space to facilitate public health transformation work, not just in Colorado, but really across the nation. And the conversation is really building tremendous momentum about how do you do this work effectively without, there are so many pitfalls to it in terms of you can worsen relationships if you, don't build trust first, if you don't manage expectations. And so there's a lot of learning and sharing happening in this space right now that I think is not only going to help us kind of learn lessons and share experiences with other groups that are working in this space, but that will also just help the collective as a bigger unit to be able to do work that we haven't really been able to do very effectively before.
And Lexi, can I ask are you guys focused on, in terms of the collaboration, is it focused predominantly on learnings from the public health lens, or is it broader than that? Because as an example, in my organization, we just got introduced to a program in South Carolina that has been profoundly impactful in terms of access to healthcare. And the learnings were pretty incredible in terms of what they did. And there was a lot of research that supported that, right? It wasn't just, it was backed by the university and there was, anyway, it was very rigorous. So I'm just curious kind of where you're pulling, where this collective group is pulling their data, information, and learnings. Is it just from the public health lens, or is it more broadly?
So great question. One of the things that is exciting for us in this list is also that the county feels like this is an important piece of work. And so we have partners in the county who do health work that's not public health work. And so making sure that as the county rolls out the work, that we're in alignment with it. Again, we're not duplicating, that we're, making
just want to say one more thing to your question, Lindy, and that is that not every program is going to be in that power sharing space. There are going to be some spaces where it's just more consultative, you know, just checking in with partners versus actually having full community members. And I will say that there are a lot of programs and when we rolled out vaccines, like out Boulder, really, we did a lot of work with them to share the power. So they were giving just-in-time trainings on gender identity and the importance of pronouns because we had 900 volunteers that volunteered. They were also helping for us to select, you know, sites. We also worked with our Latinx community to figure out, oh, schools are trusted spaces. Okay, we'll hold a vaccine clinic there. So there is a lot of work that happens every day. And we just don't always tag it. So that's what I love about the spectrum is because I think everybody across all divisions can see themselves in these spaces.
And as we go a little deeper, we also recognize that we actually need the community to tell us where they think we are on the spectrum.
Yeah.
Because we always think we're further along the spectrum. Yeah.
Right. And I would say a lot of these models are based off of like grassroots movements and social justice. And I think we're learning from a lot of kind of on the ground, innovative community engagement efforts and not just thinking about like what has that looked like standard within public health. Also, apologies. I'm solo parenting and my 7-year-old is babysitting my 2-year-old right outside the door. So that's what that was.
I mean, I think this is really great. And I also think it's another example of where public health is out in front of most, if not all other departments within the county. And so I'm glad to hear that we're working with other departments within the county because I think this is a model that can help government broadly.
Well, and it's also helpful for me to have the construct, like what the way you guys are enacting this right into reality. And I really can't.
And I think what's also really exciting is some of our partners who are guiding the work at Calfo, for instance, the person leading the work was actually on one of the teams that developed this work nationally for public health departments. She was recruited and has, I mean, one of the top experts in the country. So it'll be really exciting to see what we can do together.
That's really quick.
You've got to go first.
Oh, no, I'm not gonna say.
I think Evelyn's, are you wrapping up?
Oh, no, I was just gonna ask Jordan how much we had for.
So I see. You have questions? Yeah, I think 8 minutes max.
No, if you could just switch to the next slide.
I think Kelly.
No, I was just gonna put that there.
Okay.
Just a quick comment, and that is one of the things that y'all should know is one of the approaches I think that I hear a lot from Heather and Evelyn and, you know, a lot of our staff is it's really looking at community engagement as understanding some of our priority populations, you know, because a lot of times, you know, in a lot of places, we just kind of put our own lens on a population. And so community engagement allows us to be able to better, you know, it's authentic community engagement is what I'm saying, right? It's just, yeah. And I think that that's really important as we look ahead. It's that sort of really gathering. It's not just talking to oh yeah, this guy, you know, this person is the lead of this NGO who sometimes works with this group, so they must know everything. It's really more of that authentic community engagement with folks, which I think is really critical. Sorry.
Oh, that was perfect. We also do want to make room for questions. We put some little brain teasers or things to chew through. So if you want to like look through these questions, kind of what pops up to you, I'll read through them for those that maybe can't see it. So any questions for clarification, of course. Do any of you on the board have any experience in this space? I know we've heard a few things here and there. What are you most excited or curious about? And then also what information will be useful for you for upcoming meetings? We know that, you know, there's a lot of information in this space and sometimes you might miss on critical information, whether it's data, whether it's a picture, whether it's a story. That may help you kind of better understand our work, because as we kind of talked before, understanding the story of public health is really important here. So yeah, take some time to look through these questions. And for those in the virtual world, if you could raise your hand before speaking, that would be awesome. I think there might be some issues with the audio. So yeah, just in case, thank you.
So, I'll just say one thing that I think we have done in the past, I don't know when it happened, but, it's sort of fun for us to hear from, some of those partners you're working with in the community directly. You know, maybe as co-presenters at board meetings, when talking about various programs. Because I think that also allows us to hear directly from the community and not always, staff, although we love hearing from staff, but that's one way that it might be, helpful for the board to see this in action. At future meetings around any of the programs that are.
Great. Yeah, and I think along the same lines as, first of all, I'm very excited about this framework. So it really resonates with me, and it resonates with me personally, but also professionally, and some of the things we're doing in my organization. That, we're all kind of on the tipping edge of this, right? Like, so it's a super cool space because there's so much collaboration and innovation going on, and the fact that we're even having this dialogue is incredible. You guys know I lean towards like, what happened then? Like, what's the outcome? So I will be curious and interested in what we're learning and what best practices start to emerge, right? Like, are there things we could potentially replicate in lots of different kinds of programs, right? And so that's my curiosity.
I liked the grid and kind of where you put sort of what public health is doing and versus kind of where you assigned the different stages. And it's also just really impressive and interesting to see all the different projects. So I think it's good to remind us of all the things you do. That was helpful, and it's good to see some of these community programs that we engage with as part of public health, and also with federally funded health center like WIC and some of the projects with special care nursery. I really liked the grid, and also just the reminder of all of these, which is a lot.
I might also add something, on the strategic plan. It will be interesting to potentially identify if a program is here on the spectrum, it might be okay to stay there, right? Or is there a plan to try to take it to a different place on the spectrum? And so to identify that, the strategic plan would be helpful.
My guess is that the strategic priorities are adaptive enough that they're probably all going to be more engaged in community in that kind of right side of the spectrum. What I think you'll see with some of our programs are more like regulatory stuff.
Yeah.
It's not so much functional stuff. So yeah.
Thanks, Heather. Thanks, Kevin. It's really interesting to answer some of your questions. I don't have any experience in this space, but I'm very excited to learn more. One of my questions is, you spoke about a couple of the marginalized communities that you've worked with and that you've targeted, but is there sort of like a plan for target communities that we know experience disparities and are marginalized? I mean, in my world, right, it's Black and Native birthing people, but in Boulder County, I don't know if there's something more narrow that you guys are prioritizing.
So this is fabulous, because this takes us back to the CHOP, the community health assessment, and so much of the identification of specific priority populations as they relate to particular areas of work that we do or particular needs in the community. So that'll be an important tool for us and information reservoir for us to draw on as we become more intentional. Because often community engagement work, you reach out to easy partners you've worked with before, and part of the meaning of getting deeper isn't just going further down the spectrum. It's also recognizing that we may be missing partners that have important voices that we want. And so being able to kind of pause and do that inventory, I think, will be also an instructive part of the work.
I think we have some identified priority populations as well. So LGBTQ folks, Latina folks, a lot of our immigrant communities where English is not their first language. Even some of our more kind of geographically cut off mountain communities. lower socioeconomic status. So we definitely have been thinking about and had some strategy discussions with Kelly and the planning team around priority populations for the strategic plan. So yeah, I think there are some of these communities that we know, and there are probably pockets of communities that we don't even know that we don't know we're not serving, you know, so.
Each priority is different. Because substance use disorder is going to be different.
Mm-hmm. Yeah.
We can go.
All right, well, so there are lots of folks in our agency who are involved in this work and who aren't here tonight. So I just want to give a shout out. Again, thanks to Rachel and Elise for helping to coordinate all of these conversations and figure out what the goals and objectives are. And we look forward to presenting those to you soon. And thanks to all of our staff who've been working in this space, lending their own experience and credence. And I think one thing that speaks to the recognition of how much Boulder County Public Health has done in this space is that CalPO is tapping us as part of the leadership of that statewide work. And recently Heather Craig participated in the CDC Foundation's feedback on their national community engagement guidelines.
Yay, kudos to you for prioritizing this as an organizational.
Staff picked the priorities. We're all
Supporting the staff. There you go. Being a major priority. Appreciate it.
Thank you, Evelyn.
Yes.
Yeah.
Thanks, Heather.
Thanks, guys.
Thank you all.
Okay, item number 7, director's report.
I am not going to talk about anything in director's report. If you have questions, I'm happy to answer them.
Any questions from the director's report?
I don't have any.
Okay.
I'm not gonna ask data questions. Right.
It's okay if you do have questions. Yeah.
Is there like a universal calendar? There were so many events that were happening within each program, and you know, we've already mentioned one field trip, but I was wondering if there's like a universal calendar for things that are happening that we might be able to like drive
I
in.
am so happy to shoot this one right over to Thomas and highlight some of the work she's been doing.
Yeah, so you took a sneak preview. I think we have it scheduled for January to actually like present all the different board development, including a Board of Health SharePoint page that all of you have access to. Thanks, Kate and the county attorneys for approving it. So there will be no interactions. You can't chat with each other or like work in Word docs since that is technically board business. But with that includes a Board of Health calendar. So I can go in and put in all the different events, not just Board of Health, but also pulling in like cool Family Connects. If you want to go to the Works program, like we can schedule it on there. You can subscribe to the calendar or go in individually and copy it over. So I'm working on building that out, building out the Board of Health like notebook. So if Landry is to step in as vice president, she has all the language. So I'm really trying to develop and make sure that like we have backup to backup. So
Repository of key documents.
Yes. Wow. And trying to forecast and build out the entire next year's agenda. Things like that. So what will I come?
Thank you.
Of course. So yes, thank you. Yes.
Any other questions about the director's report? Okay, thank you. Item number 8, old and new business.
Okay, thank you very much. We actually have some new business tonight. First of all, I would like to announce that Catherine Palmer, our Director of Administration and Finance, was elected to be the new co-vice president of the Colorado Public Health Administrative Directors organization.
Yeah.
So congratulations, Catherine. I think that's going to be great, not only to have her her leadership, but also having her fingers on the pulse of what's happening around the state will be terrific for all of us. Okay, second piece of new business. We received some unexpected news last Thursday and we wanted to share the info with you all and let you know our responsive plans, answer questions that you have and ensure alignment on the path forward. So on Thursday, the Board of County Commissioners in their budget proposal workshop proposed to cut public health's county funding by approximately $1.5 million from 8.5 million to 7 million, which is about an 18% decrease in our county budget. This was proposed as a global budget decrease, so not line item specific positions, but just like you only get 7 million to decide how you want to spend it, as we understand it currently from direction from the Office of Financial Management. So we were expecting cuts in the coming years due to declining county revenues, and we had already started working on a 3-year strategic budget to pull in, get more efficient and effective, and really focusing on being strategic and creating graceful transitions, minimizing impact to staff. But this decision came sooner than expected. We didn't expect it to happen this year, and it came without warning. And we will need to accelerate some of our plans for increasing revenues, creating efficiencies, and ensuring our agency is on solid ground to address community priorities. We recognize that these kind of changes are really stressful for our staff. So we did have a conversation with staff today to create an open space for questions and to hear. And we will be working with staff going forward to make sure that they are getting regular updates and that they have opportunities to weigh in on what we're deciding together. The final budget decision will be made December 5th. So this was a proposal. They will make final decisions December 5th, which leaves us not a lot of time for planning and making adjustments to our final budget for the Board of Health, which are due at the same time. So what are we doing in response? First of all, we just want to note that it seems like a little bit of an odd choice because it feels like there's a lot of risk that the county is taking on with this decision, because this will certainly affect services and relationships with partners and give us little ability to help them transition. So much of our work involves community partners and we don't want to leave them in a lurch. And I'm concerned about how it will affect trust with the community. And the community sees Boulder County Public Health as squarely part of the county. So a little bit concerned about that. And we also feel like there's some really strong arguments to request a delay or at least a decrease in proposed cuts. I don't know how realistic that is. The reality is that as much disruption as this will cause for our department and our staff, and unfortunately, Catherine and some of the rest of us going back to working ridiculous hours to make this work, the impact on the county budget is 0.003%, not 0.3%, 0.03 thousandths of 1%. So this is, it's hard to understand why this was an urgent cut. So we feel like it's more trying to send a signal, but we have not gotten any information other than we'd like you to reduce duplication of services, which we are working on, but need time to work through that because it's easy to cut things. And when you do that, you create a lot of unintended consequences and a lot of pain for folks. And to do it in a way that minimizes disruption of services and staff and keeps families intact takes a little bit more time. So we are currently working with the Office of Financial Management to determine what flexibilities we have to optimize our response and create a revised 2024 budget quickly. We are also confirming whether our budget has to be balanced for the December Board of Health meeting. We're getting conflicting signals. Our previous director said that he once passed an unbalanced budget. Jana Peterson, our county administrator, also mentioned that that was an option, but we really want to confirm with legal just to cross our T's and dot our I's. We are also going to continue to accelerate our 3-year budgeting, strategic budgeting planning, starting immediately to identify areas to tighten up that are low-hanging fruit, and to accelerate our plans for revenue generation and new grants. and identify areas of work we may not need to be doing, including in relation to county departments and community partners efforts. So where can we lighten our space? We're reviewing and reallocating our reserves and asking programs to tighten up program costs when they can identify them. We may need to re-examine hiring plans and timelines, utilize internal hiring more, get a better handle on what kind of attrition we can count on, and explore additional efficiency opportunities. The trick is that when you cut staff, you also have to cut services where you're just increasing workload for the remaining staff. And so that is really critical because workload is one of the biggest stressors on public health staff right now. We're just recovering from an outrageous workload. Folks are still, stabilizing and regaining their mental wellness right now. And we don't want to put them in a position of going back into significant overdrive. We're also engaging budget analyses and projects to fully and projections to fully recognize the impact of the proposal, including unintended consequences we and/or the commissioners may not recognize yet on public health or partner efforts, or that may affect future budgets and needs we would have to plan for. Because as we start to look at the numbers that we would need to address, we also have additional funding cliffs coming up. We have $2 million in ARPA funds that go away for 2024 that we've been working on already. The WIC formula is likely to change in the future to require a local match. So there's some interesting challenges in front of us in that space. Our highest priority is not to lay off staff just because we have budget cuts, but to be thoughtful and graceful about really looking at our agency and its strategic impact and where its best investments are. And we also hope not to reduce merit and COLA plans for 2024. We feel it's really important for public health to stay in alignment with other county departments. We are county staff, both as a matter of respect for staff and for equity. We have worked really hard over the last 2 years to rectify a lot of more than 50 funding inequity positions that existed for years in public health. We have been able to rectify in the last 2 years, and we really don't want to backslide in that space. So next slide. So this is just an example of kind of where this funding cut leaves us compared to other counties. The first column is what percent of public health funding comes from the general fund. And you'll see that Boulder is currently at 33% and it would drop down to 26% with this vote. And the second column is how much the county spends per capita in public health. So it would drop from $25 to $20, which is a 20% decrease. Okay, so it'll take us to the lowest level in the metro for percent county contribution to the budget and reduce per capita by $5 each person. So we do have a couple of questions for you. Love to hear your comments, but one of the important questions, we really wanted to share this with you tonight because when we come to you in December with the final budget, we need to know what your expectations are. If we are legally able, are you comfortable approving an unbalanced budget in December with an agreed upon clear process and regular reporting to reach a balanced budget by the time we present the operational budget in the spring? In consultation with our previous public health director, he said that they had done that previously with the board. But I recognizing that this is a little bit of, we're still working through a lot of, how do we make sure that the Board of Health is comfortable with their oversight role, and budgets are really important, one of them. We want to make sure that we're in alignment with your expectations. The challenge is that if we actually have to create a balanced budget by December, it will not be a smart budget. It's not going to be intelligent. And we will either have to revise it significantly or face an awful lot of consequences, I think. The second question we have for you, and of course, we're happy to hear any, requirements that you would like attached to that if we didn't. If we decided that it's okay to not present a balanced budget. The second question is, are there any actions you'd like us to take before the county commissioners vote on the final budget on December 5th? And we're happy to answer any questions. We've got Catherine on the line for technical
We
stuff.
have an opportunity to present this data, make a plea to them, reconsider this decision.
Not yet. We wanted to talk to you first.
Can you make that? Because that just seems illogical. It's like a political statement rather than a practical choice.
Yeah, so my initial reaction, Lexi, to the unbalanced budget is if it's allowable, I think that seems like a prudent path, given we do not want a budget that is not going to reflect reality. So as fiscal stewards, I feel like that is the prudent way to go. If we're not allowed to do that, then obviously we will do what we need to do. To the commissioners, I am really concerned about the dynamic with the commissioners. I'll just say that very publicly. I feel like I'm confused a little bit by, there seemed to have been some engagement, but I am unclear where their priorities are, right? Because they impact our priorities. And I do not feel like we've gotten that clarity from the commissioners. So I would like to propose that, and it doesn't necessarily need to impact this process, it could, but I would like to have better clarity from their commissioners about their public health priorities for this agency and what we need to be thinking about as a result, because I do not feel like we've got that clarity. And I am happy to help shepherd that conversation, Lexi, personally, but I don't know if that's the right path, but I think, I'm feeling a little bit like we've danced around some questions, but we've never gotten at the root of potentially, what the priorities are. I also just, to your 0.0003% remark, am wondering what sits underneath this, right, for us. And if we don't align now, right, what's the conversation in a year? So it just feels like this sort of underscores the importance of that dialogue.
Yeah, thanks, Wendy, for that too, because I find this to be very disappointing from the commissioners. And I think that in particular, I'm disappointed by the lack of transparency from them, that if they were anticipating that this was going to be even a possibility, that they did not give us at least some time to work this into our budget planning. Because, although it would have been disappointing 6 months ago, it certainly would have been a lot more time for us to work around this. So I think really disappointing. I think there should be a response from the board to follow up with asking for more information about why and also clarity around their priorities. I mean, I think they shared at a meeting with us that they were prioritizing staff of the county when looking at their own anticipated budget shortfalls 3 years from now. And this feels out of alignment with what they told us. So really disappointed. And I feel terribly for our leadership team and our staff to have to respond to this, particularly Catherine. I know how much time you put into preparing so many budget materials for their decision making, and it doesn't feel like that is reflected in this either. So I there's my statement of disappointment, and also that I think we need to strategize what a response is, ideally to give us more time to respond, but whether or not that's even possible, to just think more strategically about what they see as their priorities and how do we align ourselves. So I do have a practical question about our budget reserves and what we are able to do to mitigate this cut using reserves.
So that's something Catherine and I have talked about, and I'll let her speak to the specifics in just a second, but the strategy of looking at our reserves and using that first to buy us time to plan so that we're making more intelligent decisions. But Catherine, please go ahead.
Yeah, so Catherine Palmer, Director of Admin and Finance, I use she, her pronouns. Thank you for the question, Morgan. What I would share in this space is, yes, it does give us a little bit of capacity to work strategically around some of the areas that we've already identified. And we really want to be careful in this space because we've worked very hard to get ourselves to a sustainable reserves. And this is causing us to have to backtrack a little bit in that space. So acknowledging that as we consider that component, how we will work back to get us into a sustainable space, especially recognizing that we don't know what will happen in 2025. And we don't want to pull away from our reserves fully. Because we recognize that if we were to just use our reserves to actually cover this, we could this year, but it would put us in a pretty detrimental spot. So we need to be able to think about it from that longevity perspective.
Yeah, just to clarify, if we spent our reserves just to shore up this year, we would be under our legal limit. Or what we're supposed to hold. I also want to make a math correction. It's not 0.0003%, it's 0.03%. Just for the record, still not very much. And I think part of kind of what we've talked about on the management team about this, we just had, directors had a little emergency meeting, and then we talked to the management team, and then we talked to staff. But the real crux of it is, we understand the budget needs of the county and the challenge that they're facing. And we are working towards that. And the timing, the rush to make this cut this year. The other thing that I'll mention is they didn't cut any other departments. It was just public health.
That's what I was gonna ask as well, and there was no rationale provided.
There was no rationale provided. The same week that they proposed that budget, they asked us to work with HHS and community services to identify duplication of services. It's like, totally happy to do that. That's a great idea. I've proposed it before. Yes, let's look at our programs and see how our systems fit together, but we can't do that in 4 weeks. So buying some time, I mean, even if they reduced the proposal by half, that would be an enormous difference for us. So that's what we're up against.
So Lexi, tactically, I don't know if there's anything that we can help with. So if we're in, we have to play out all the scenarios, right? If we're in a scenario where we're having to manage this and there is no ability to go with an unbalanced budget, or even if there is, there's something we as a board can do to help with the process so that it is not so burdensome. I have no idea if that's feasible or not, but what I don't want is for the staff to feel burdened because of the board needs, and we can have more discussion about what that is, if that makes sense, and maybe be more collaborative along the way versus having to amass a giant analysis and report for the board. So that may have no relevance, but I just wanted to throw that out there as a suggestion to help if, because recognizing what day is it? It's November, we're almost at Thanksgiving. So yeah.
No, I appreciate that. Do you want to speak to that, Catherine?
Yeah, so that was actually one of my questions to you. So thank you for asking it, Lindy, was as the majority of you, except for Amber, which I have yet to meet you in person yet, but I look forward to it. When we presented the recommended budget to you previously and did the work session, a lot of that was based on what we thought was going to occur. Now with this very different change, a question I have in this space is typically when we bring the budget resolution to you in December, it's more of a performative approach where we're just presenting it. We touch it briefly, and then you do a vote. But wanting to know what you would like to see in that space to understand some of the analysis that has gone into this work because the numbers are going to look different.
So I think the question is, what would you like to see in that December presentation?
I think it'd be helpful, you're probably already doing this, I just certainly don't wanna burden you with any additional work, but things that you're looking at to target for the duplication and also areas where you could revenues be useful to know, but I don't wanna, I certainly don't wanna contribute to any added stress. But I'm sure you're already doing that.
Yeah. And the other thing I want to.
Beautiful spreadsheets already.
Already.
The other thing I'd like to share with you maybe is the video of the all staff meeting where you can hear from the staff. It was 10 minutes of presentation, 20 minutes of
30 minutes.
30 minutes of staff questions. So I think it would, and we wrote them down and we can share those too, but I think you might have similar questions. So I think that would be really helpful.
Could you also send the link to the commissioner's presentation?
Yeah, and I put that into the notes too. Commissioners.
I mean, can the commissioners see the video of the staff responding questions?
Sure.
I mean, I just wonder, let's review it first, but I do think that the commissioners need to hear about what the impact is gonna be, because I'm not sure that they are recognizing what the impact is going to be.
Well, I will tell you that we have an amazing staff, and there was a lot of positivity expressed and solidarity expressed today. And my experience in this journey is that there's a few days of shock and then it sets in and you start having a different emotional reaction to it. So just to know.
Yeah, and we have committed to the staff to stay as transparent.
Yeah.
I mean, regular updates.
That's really the best you can do. I mean, you can't, and I think everyone will acknowledge this is literally out of your control. It's not like you decided this. This was a decision made for the organization. I wonder if we should, I don't know what the appropriate protocol is, but to offline, maybe there could be like a smaller group that comes together, Lexi, with you on a strategy. If it's helpful from the board, I feel like we would like to support the next steps, but I'm not speaking for the whole board, but I feel that way and I'm seeing head nods that we would like to, stand behind and help support this as much as we can.
Thank you. I really deeply appreciate that. And I mean, it's hard to say it enough, but I understand we need that the whole county is gonna feel some pain. It's the timeline.
Right.
That isn't resonating well. And I think it's critically important for us to also figure out how to better communicate what we're doing and how it interstices with, 200 other community organizations and county departments, and what the loss will be and how to better, present data for their budget decisions in 2025. Because if we take this cut this year and then we get another cut next year, that's hard to process.
I'd like to suggest that there be like maybe some short-term objectives to review what the staff are asking questions on, and then maybe look at, what questions you have for follow-up and figuring out that plan versus and then going into the December board meeting.
Yeah, I guess, what I'm trying to figure out is how the board can be helpful as you're trying to figure out what you're going to bring to us in December without us, I mean, I just don't think we're in a position to tell you, like, here's where I would look to cut, right? I mean, this is what what you need to suggest to us. So I think what would be helpful, Catherine, as you're preparing materials for us for December is, here is what we recommend. This is what we, are putting forward this is our preferred path. If you don't like that, here's a couple of other things we could consider. So like, this is our preferred path. This is what we recommend. But, here's one or two other things. Does that?
Yep.
Resonate with you? Yeah. because again, we want to minimize your work. And so if you really have one plan that is the plan that is how you're going to navigate this, then that's okay too. But you know, we are not in a position to tell you
Sure.
like this is.
I guess the immediate question for me is, I don't know what the potential is, but is it worthwhile to have a conversation with the commissioners about the impact?
That is what I think our immediate task is, and I'm trying to navigate this forum and decide like what we say here, but I think we need to have a strategy in our communications with the commissioners. That's very clear to me, and I do not think this should be a silent dialogue board. So.
Right, given our tight timeline, right, we probably need a subcommittee. I think we can have two of us.
Nominate Lindy.
Doesn't have to be me, but I feel very passionately.
Yeah, and I feel like as board president, I'd like to be a part of that. I'm, you know, and again, as background, I did join Lexi and Catherine in a meeting with two of the commissioners to talk about budget a month ago, I think, and we had, I mean, no signal that this was coming in that discussion too. So I feel like there were multiple opportunities to give a signal. Signal was not given. So I.
And yeah, and I think there's
Reiterate.
a deeper understanding of the rationale and. you know,
Yes.
I'm also concerned about this from a relational perspective moving forward. To your point, what happens next year and how do we open this dialogue so that it's more transparent and it's more planful and manageable and hopefully that won't be a dialogue next year, but we need to anticipate the pressures of the county.
Sure,
Yeah.
yeah, and I think we have been anticipating the pressures of the
Yeah.
county. I mean, that was part of
Yeah.
our budget discussion in our budget planning session. So we can have a subcommittee meeting and then we can figure out that strategy. And then the challenge is always getting onto the commissioner's calendar, so.
Is that, Lexi, does that sound reasonable to you in terms of the next step?
Sure.
Catherine, does that give you enough information for a December meeting?
I think so. I I think what I recognize in this space, this is where maybe just a little bit more clarification. So when we bring to you recommendations and other options, do you want that, but also, and maybe this is also a question for Kate, is can we shift from that directly into a resolution, or are we only making the recommendation and then having to do a follow-up meeting to do the resolution?
The answer to that right now, but I'm writing it down and we'll follow up before then.
Okay, thank you.
And I guess it's also hard to think about whether or not you could send us those plans ahead of time so that we could really thoughtfully review those. Again, I recognize we're up against such a tight time crunch, so.
Well, and I think if you're comfortable with, for instance, this is much we have that we could put towards from reserves.
Yeah.
This is our anticipated attrition
Yeah.
this year for.
Where, like, yeah, exactly.
Right.
Where are you going?
This is, you know, how much we would raise by X. And then we've kind of also started to put together, you know, a whole list of potential contingency plans. Indira's working hard to figure out if we can get Medicaid stood up as soon as we can, you know, that could provide some relief. There are things that we already wanted to do, but we just need to move much faster now. And sometimes it's hard to project kind of how much we would be able to save, but we can give some ranges and some options and we can prioritize them and then, you know, figure out what that looks like. I think the other thing that's important to know too is that that 1.5 million isn't quite all of it. We also are taking a hit on the HHS funds that were approved back in June by HHS, but were not approved by the county commissioners, which includes position that won the county commissioners award, Pinnacle Award. I think they probably don't recognize that they cut that position. It doesn't mean that person's leaving, but it's ironic. And then we did get approved our S-tax portion that had been approved in previous years. We did not get the portion of the S-tax request that was new, which was another 150,000. So just to give you the full rounded out. And Catherine is also currently working with the finance team because that 1.5 million actually may be a bit higher when they start to process some of the FTE information. Do you want to say more about that, Catherine?
I do, but I couldn't find my mouse. So, yeah, in the work that we're doing right now, and this is the typical flow and process, as we really tighten up the budget just before the Board of County Commissioners approves their budget in December. We do one final look at the FTE numbers, and as well as the agreements that the Board of County Commissioners has made around merit and COLA. So now that those have finally been applied, they send us one final data sheet and we review it to provide feedback. We've already found at least 8 lines of discrepancy and substantial discrepancies. So we know that the number is going to shift, and I'll actually be submitting that to HR tomorrow. So we'll have some dialogue in that space.
A couple big unknowns, like is a balanced budget an unbalanced budget allowable, and can you delay this? Do we have any idea when we'll get answers? Either of those?
I should have more information next week. I'm planning to meet with Ben Perlman, the county attorney, and some others in my office on Monday.
Thank you, Kate. You are always such a remarkable support to public health.
Yeah, no sweat.
Kate also works with me in the meth and the environmental health team in the meth space right now, and it's just Kate, thank you so much. You do so much work for public health.
She's got her own jacket.
She's a jacket.
COVID got her first. I do have a question for the board. It feels like, you know, I feel like the intention is not to rush on certain decisions. So am I hearing correctly that the idea for December is to kind of bring some closer numbers that Catherine has, and then also to look at some options, and then we take it from there? Is that?
But we have to pass a budget resolution. I think that's my concern, right? Is that we have to pass something. So.
But does the budget have to be completely accurate?
That's what Kate's gonna be.
Right. And what's the timeline for updating it as we work through some of this? But no, I mean, I think Indira, we just have to pass something. And we need to know how accurate it has to be and how much, and again, what's the timeline for when we would adjust that and whether it has to be balanced. So I think the goal for December is having something that we can pass.
But not necessarily making decisions.
Oh, right. I mean, I think the question is though, like, if we pass a budget resolution, how tight are we to that also? I mean,
Well, and that depends on how microscopic we have to get in budget resolution.
Yeah.
Right, if there's enough flexibility. We can.
Yeah, the more flexibility, the better.
Yeah, great.
Okay.
I'm thinking about that to your very good.
Yeah, because it is a tight timeline, and also we want to be very thoughtful.
Sure. And I just want to take a moment also to just appreciate the staff and how much the staff has been through in the last several years. And just that we want to support the staff as we're going through this. So feels really unfortunate and unfair.
So sorry to end on a down note, but Catherine was voted the co-vice president of COMAD.
I'm talking about you.
More work now.
She's highly connected now.
And we had some great presentations tonight. So
Oh, yeah.
Yeah.
Really happy to
Yeah.
share that with you.
This is a little bit of a Debbie Downer.
Yeah,
A little bit.
gotta tell you. Yeah.
Thanks for letting us know.
Okay, item number 9 is adjournment. Meeting 7:53. Meeting to close. Thank you.
Thank you.
Yeah.
Sorry we ran